Bismillahirrahmanirrahim. Assalamu alaikum. My name is Adit and my moderator is Dr. Mazhar Ali. Today we are going to discuss benign renal masses, learning object diagnosis of benign renal masses, angiomyolipoma, oncocytoma, and other benign tumors, including renal cyst, papillary adenoma of kidney, metanephric adenoma, oncocytoma, angiomyolipoma, cystic nephroma, leiomyoma. Renal cyst. Up to 10% of population may be aware of renal cyst. 70% of asymptomatic renal masses. They may be solitary or multiple. They may be unilateral or bilateral. Risk factor included age, male, gender, hypertension, renal insufficiency. They are mostly sporadic familial syndrome APKD, higher incidence of RCC associated with cystic disease. Diagnosis. Diagnosed incidentally can be imagined through variety of radiographic technique, including ultrasonography, CT scan, MRI. Ultrasound. The picture showing simple renal cyst, smooth wall, fluid filled, no internal echoes. This is the classification for the renal cyst, Bosniak classification. They are basically four type. One, minimally smooth thickening of their wall or septa contain calcification. They may be thick or nodular, but no measurable contrast enhance is present. Totally intrarenal, non-nasing, high attenuation renal lesion, equal or greater than 3 centimeter are also included in this category. Incidence of malignancy is 18.5%. For therapy, repeat imaging to assess stability of size and radiographic characteristic. 3. Indeterminate cystic masses have thickened, irregular or smooth wall or septa in their measurable contrast enhancing is present. Incidence is 33%. For therapy, it requires excision and ablation. Type 4 clearly malignant cystic masses can be all criteria of 3 but contain nothing soft tissue component. Incidence is 92.5%. For therapy, it required excision or ablation. This is the picture showing type 1, 2 or 2F renal cyst. And one, they are simply hairline fluid filled cyst, while 2 contain septa, while 2F contain multiple septa. Is type 4 and 5 or bifid, while 4 and 5 contain also solid components. 5, 3 and 4. 3. Treatment. Occasionally, renal cysts require treatment because of the local symptoms such as pain, infection, hypertension, hemorrhage, or traumatic cyst rupture. Management can include aspiration, cyst decortication, cyst resection, sclerotherapy, arterioembolization, and even nephrectomy, depending on the cause and symptoms. Other, we are going to discuss oncocytoma. Up to 25% of the renal masses smaller than 3 centimeter representing oncocytomas, 3 to 7% of renal tumors. According to recent study, its incidence is increasing in older age patient and female, genetically related to chromosome 1 or 14. These are arise from intercalated cells of the renal tubules. Sporadic, most common, can be related to the Bret-Hawk-Dobbs syndrome, 12 to 34%. These are usually asymptomatic, but they can be presented with gross hematuria, flank pain, and palpable masses. In 30%, they can be multiple. Renal oncocytosis, presence of multiple concurrent oncocytoma with or without RCC. While in 32% of cases, oncocytoma and RCC may coexist. This is a pathology. In pathology, grossly, these tumors have brown surface similar to the appearance of normal renal parenchyma with a variable present central scarring. Originate from the intercalated tubule cells of the collecting tubules. Classically strongly eosinophilic because of the high mitochondrial density with nest and tubular structure arising from the distal tubules. Nuclei tend to be round and regular with extremely rare mitotic figures. Oncocytoma can be associated with perirenal fat inversion and renal vein inversion. Eosinophilic variant of the chromophobe RCC and oncocytoma are histologically almost similar to additional pathological testing required. Immunohistochemistry sufficient to establish the diagnosis pathologically. It's recommended to use immunohisto differentiate oncocytoma from the malignant tumors. In a case in which the diagnostic dilemma is between the chromophobe and oncocytoma, cytokeratin 7 CK7 can be useful. CK7 is not positive in oncocytoma, whereas chromophobe RCC tends to be diffusely positive. Where albumin is 100% of RCC and 47% of oncocytoma. Radiologically, ultrasound basically demonstrate a well circumcised mass with echogenicity similar to the rest of the kidney. Occasionally a central scar may be present, while CT scan tends to be a large well demarcated tumors are present at presentation. Non-contrast if less than 3 centimeter, homogeneous attenuation. If it's greater than 3 centimeter, then heterogeneous attenuation. Perinephric fat staining may be present due to edema. Calcification may be also present while in non-contrast CT scan. In post-contrast, smaller tumor may be enhanced homogeneously. In large tumor, usually enhancement is heterogeneous. Central stellate non-enhancing scar is seen in the approximately a third of the cases. Renal vein thrombosis may be present, but tumor thrombosis is not present. However, these alone are insufficient for a definitive diagnosis. This is the picture showing oncocytoma of left kidney with central scarring. MRI typical signal characteristic including T1 hypointense compared to the renal cortex, T2 hyperintense compared to renal cortex, maybe demonstrate hypointense and central stellate scarring, while T1 usually demonstrate homogeneous enhancement. Angiography may demonstrate a spoke wheel pattern. This picture is showing angiography with the spoke wheel pattern. This is the MRI showing oncocytoma. Most recently, research into technetium-99 STIMAB single proton emission computed tomography or X-ray computed tomography has been studied with a sensitivity and specificity of 87.5% and 95.2% respectively. Prognosis and treatment. They usually have excellent prognosis. Since 20 to 45% small renal masses are found to benign, active surveillance is needed. In most cases, observation is required elderly or sick patient. In young symptomatic patient, treated it by a surgical resection. Young patient, if there are symptoms are present, then we go for any surgical resection. Due to benign nature of this tumor, low recurrence nephron-sparing surgery is indicated. Frozen section analysis can't differentiate between RCC and oncocytoma, so not recommended. Angiomyolipoma. Now we will discuss angiomyolipoma. Benign renal intensity composed of variable amount of 3 components. As angio means blood vessel, Myo means plump spindle cells, while lipo means adipose tissue. Epidemiology studies estimate that the prevalence is at 0.13% in general population, while females are predisposition female more common in the fourth and fifth decade of life. Classification of AML. These are mostly sporadic 80%. They may be unilateral or slow growing. These are unifocal. Hereditary 20% is associated with tuberculosis sclerosis. Bilateral, multifocal, aggressive, and symptomatic. Among these, TSC patient have prevalence has been reported from 55% to 90%. Histologically typical or atypical epithelioid have malignant potential. Pathologically, on a gross examination, tumors are well circumscribed with a tan, pink, yellow surface depending on the fat contents. Two histological types has been described. This is a basically typical or atypical. While typical is triphasic, atypical is monophasic or epithelioid AML, characterized by minimal fat content and an absence of epithelioid cell. Atypia within the epithelioid cells. The presence of mitotic figures necrosis are common and suggest a more aggressive course. This is the histopathologically showing these are the vessel, uh, spindle cell, fat, the thick hyaline vessel with a eccentric lumen. Immunohistochemistry pathologically mimic AML is including sarcoma, especially fibrosarcoma, leiosarcoma, and liposarcoma, and renal cell carcinoma. Melanocytes marker HMB45 melanin are important immunohistochemical stand to aid in the diagnosis when in a doubt. AML stand strongly for estrogen receptor B and progesterone receptor and androgen receptor, which may explain the postpubertal female prognosis. Radiologically, diagnosis of AML can be made on imaging ultrasound. While in ultrasound, we will see that there is a well-defined echogenic with a posterior acoustic shadowing. However, this is not a pathognomic of AML. In tuberous sclerosis, they may be so numerous that the entire kidney is affected. Appearance of echogenicity with loss of CMD. CT scan. On CT scan, presence of intralesion fat minus 15 to 20% Hounsfield unit on the non-enhanced series is diagnostic. Up to 5% of AML are the fat poor, especially in tuberous sclerosis. Absence of calcification favors the diagnosis of AML. This is the picture which showing angiomyolipoma. MRI. MRI, excellent diagnostic modality for the fat-containing lesion. Two main set of sequence are employed: T1, T2. T1, T2 hyperintensity enhancement on the gadolinium administration. Hypointense on the T1 fat suppressed sequence in the phase out of the phase imaging generate India Inc. artifact between fat and non-fat component. This can occur at interference of the kidney mass or between the fat and non-fat component. Although the diagnosis can be confidently made on imaging in the most circumstances, fat poor AML, which resembles RCC, fat containing RCC, and liposarcoma, unique situation in which the diagnosis can problematic on the imaging. When the fat poor AML is considered, percutaneous biopsy has been useful in the determining the diagnosis. Approximately 4 to 40% of AML do not contain radiographically identifiable and appear similar to RCC or standard imaging. In that case, MRI is helpful. Clinical presentation, how the patient presented with symptom. Mostly the patient, some of the patient present asymptomatically, incidentally discovered on the ultrasound, while patient may be presented with a flank pain, palpable mass, painless hematuria, Wunderlich syndrome. This is a basically spontaneous massive retroperitoneal hemorrhage, acute flank pain, flank mass shock, 10% of the cases. Uh, 20 to 30% occur in a patient with tuberous sclerosis complex. There are four mainstay of therapy. This is basically surgical resection, thermal ablation, embolization, systemic therapy with mTOR inhibitor, using response evaluation of criteria in the solid tumors to the assess response. The combined 12-month response rate is 50% reduction in the volume or 30% reduction in the longest diameter was 46.8%. Treatment included active surveillance, asymptomatic or solitary or tumor less than 4 centimeter, or aneurysm may be present less than 5 mm. 6 to 12 month imaging by ultrasound to document growth rate. For hereditary, MRI yearly for the tuberculosis complex. Intervention required. When the patient presented with symptoms, size should be greater than 4 mm, aneurysm should be greater than 5 mm, highly vascular. Women of childbearing age, suspicious of pregnancy or suspicious of malignancy, risk of loss of follow-up. This is basically a flow chart representing the treatment for AML. If no AML, then we go for the biopsy or further imaging. Still equivalent or malignancy is suspected, then RFA or cryoablation only in the selective cases with the small tumor, or partial or total or radical nephrectomy is preferable. CT MRI or CT or MRI diagnostic of AML is equivocal biopsy or further imaging. Still equivocal or malignancy is suspected, then we'll go for the same RFA or cryoablation or partial or total radical nephrectomy. AML, if AML symptoms, then we go for the, or then there is a tuberculosis complex suspected, then genetic testing if TS is not yet confirmed. Then we go for the selective arterial embolization in the cases of hemorrhage, shock, or limited renal reserve or poor operative candidate. Or patient if asymptomatic, no TSC, less than 4 centimeter or greater than 4 centimeter with intralesion or aneurysm greater than 5 mm, then the patient may need surveillance with remaining, except in the female of childbearing age or patient with a poor follow-up. Next, we will discuss papillary adenoma of the kidney. In 2004, the WHO defined papillary adenoma as a low-grade, grade 1 or 2, well-circumcised cortical lesion, measures less than 0.5 centimeter. Incidence increases with age, male sex, end-stage renal disease, acquired renal cystic disease, sporadic RCC, and hereditary papillary adenoma. Histologically, cells are uniform with a benign nuclei are arranged as either tubular papillary or tubopapillary, similar to papillary RCC. Rising concern about the potential that the papillary adenomas are premalignant lesion. In addition, supporting these concerns is the similar aminohistochemical staining, is the alpha methyl CoA racemase positivity, and cytogenetic changes such as trisomy 7 and 17 of papillary adenoma and papillary RCC. Because of the papillary adenoma are by definition less than 1 centimeter in the size, they are often diagnosed pathologically as concomitant finding with RCC and therefore required no further directed therapy. Although the diagnosis of papillary adenoma are benign tend to remain controversial, this changing paradigm of active surveillance for a small renal masses certainly support observation of these small lesion with when the papillary adenoma is considered. Next, we will discuss metanephric adenoma, a rare benign epithelial lesion in the kidney that has been described in the literature, mainly through a case report, representing approximately 0.2% of renal masses. It can present at any age, although the peak is in the fifth decade and is found more often in the female, 2:1 in female or 1 in male. Approximately one half of the patient are diagnosed incidentally. The remainder experience symptoms such as flank pain, gross hematuria or palpable mass and polycythemia. These are the symptoms usually patient presented. Pathologically, grossly, these appear well circumcised 10 brown masses that has been reported up to 15 centimeter. They found that all cases contain uniform cell with blunt nuclei and scant cytoplasm, where architecture was described. Acinar, follicular, tubopapillary, and glomerular structure were reported. Aminohistochemistry beneficially in the distinguished papillary RCC from the entity wet positive for the Williams tumor protein WT1 or CD57 negative for the alpha methyl acyl CoA racemase, whereas papillary RCCs 10 positively. Meanwhile, the papillary adenoma are notable for the cytokeratin 7 and epithelial membrane antigen positive, whereas the metanephric adenoma are negative for the markers. Together, this description of histological and aminohistochemical method to differentiate metanephric from the alternative diagnosis may suggest a role for a renal mass biopsy when suspicious is high for such benign intent. Radiologically, on the CT scan, these masses appears hypovascular with minimal enhancement and calcification. These are show progressive but lower enhancement at the each phase of a contrast enhanced CT scan. Notable enhancement was uniformly less than that of the renal parenchyma, a finding in contrast to RCC in which a rapid hyperenhancement is common. Cystic nephroma. Cystic nephroma is a rare benign tumor that occur in young boys predominantly 2 to 3 years of the age and adult female predominantly 4th or 5th decade of life. Radiologically, these tumors are soft, solitary with central cystic masses with calcification, extension to the collecting system and septal enhancement. Given this appearance in child, cystic nephroma is difficult to distinguish from the Williams tumor and is often diagnosed after a surgical resection. Pathologically, Encapsulated cystic lesion line with a cuboidal and obnal epithelium in a stroma where variable composed of collagen and spindle cell vesicle. Aminohistochemical stains are notable for the cytokeratin positivity in the epithelium, with stromal elements stain for CD10, L-retinine, inhibin, estrogen, and progesterone. The key finding that differentiates cystic nephroma from Williams tumor is lack of the blastemal and embryonal element in the resected tissue. Mixed epithelial and stromal tumors. Mixed epithelial stromal tumors are benign tumor of the kidney that are most often identified in the perimenopausal women, often with a history of estrogen replacement with a peak incidence in fifth decade. In the men, this has been reported after a long-term hormonal deprivation for a prostate cancer. Importantly, malignant transformation has been observed in a primary lesion. Uh, these transformations are observed in the stromal element with a sarcomoid feature, and poor clinical outcomes are suspected. On radiological evaluation, these mixed epithelial stromal cells often appear to a complex cystic mass such as Bosniak similar to the RCC. Grossly, tumors are identified with the mean size of 6 centimeter and are encapsulated with solid and cystic component that often extend into the renal pelvis. On microscopic evaluation, these are cystic component variably lined with cuboidal and columnar epithelial, although the urothelium can be seen as well. Interseparated in the stroma of the spindle cell, smooth muscle vesicles and collagen bands are present. Aminohistochemical staining reveals estrogen and progesterone positivity in the stromal element along with mesenchymal tumors such as Bementon, CD34 and Desmin. Meanwhile, the epithelial component will stain positive for the cytokeratin 7. Leiomyoma. Leiomyoma is a rare renal tumor of smooth muscle differentiation. This tumor can arise anywhere in the urinary tract. The bladder is the most common site. Within the kidney, multiple site has been described. However, the renal capsule is the most often described location. Basically, these are found more often in the women, 2:1 ratio, and account for a 0.29% for a primary renal mass. Radiologically arise from the capsule. Radiographically, they appear as small exophatic masses, and the hyperdense on non-contrast CT scan with hypo enhancement on the intravenous contrast administration. Although this enhancement is less than that observed with a traditionally clear cell RCC, chromophobe RCC tend to have hypo enhancement similar to the leiomyoma, making the radiological diagnosis difficult. Pathologically, on a gross examination, these tumors appear well circumcised and firm. Tumors can range in a size, may have associated with calcification or focal cyst degeneration. Microscopic examination demonstrate spindle cells that form intersecting vesicles without evidence of hypercellularity, pleomorphism, mitotic figures, or necrosis. Aminohistochemical staining is notable for the Bementon and smooth muscle marker Desmin and Kel-Desmon. Interestingly, leiomyoma can stain for HMB45 because AML is on the differential for a leiomyoma. The key factor differentiating these entities, including the absence of melanin A stain and the absence of the adiposity in the leiomas. There are some other benign renal tumors which are including hemangioma, lymphangioma, juxtaglomerular cell, renoma, interstitial intrarenal schwannoma, or solitary fibrosing leoma. Renoma is the benign tumor of renal juxtamedullary cell appear in the appearance is an important that cause secondary to hypertension or hypokalemia lead to be hyperaldosteronism. Thank you.